Hello, and welcome to your lecture on labor and birth. Some learning objectives for this chapter include identify premonitory signs of labor, compare and contrast true versus false labor, categorize the critical factors affecting labor and birth, analyze the cardinal movements of labor, evaluate the maternal and fetal responses to labor and birth, examine the concept of pain as it relates to the woman in labor, classify the stages of labor and the critical events in each stage, characterize normal physiologic/psychological changes occurring during all 4 stages of labor. So we're first going to talk about the passenger. Now there's 5 P's of labor that we're going to review. So the passenger is actually the fetus itself. We're going to take into consideration the size of the head. We're going to look at the fontanelles. The anterior is closed by 18 months, and posterior fontanelle is closed by 6 to 8 weeks after birth. Now the head goes through a process called molding as it's delivering through the vaginal canal. And this molding is necessary to be able to accommodate the fetal head delivering vaginally. Fetal presentation can be cephalic, so this is head down. We also refer to this as the vertex, and we're going to talk about that in just a few minutes. Breech presentation, there could be many breeches. There could be a frank breech where the buttocks is presenting and the feet are extended. A complete breech where the baby's pretty much just Indian style. And there can be footling breech where we have 1 or 2 feet presenting. And then of course a shoulder presentation or the scapula, okay? So that's pretty much where we have the baby in a transverse lie, which we're going to talk about in a minute, and pretty much horizontal, okay, positioning. So shoulder presentation and breeches are always delivered via C-section, unless you have a frank breech that's crowning with the buttocks presenting. Okay, so that's where we're kind of committed to delivering. But any other breech delivery we don't typically do. It's very, very risky. The fetal lie is a relation of the supine of the fetus to the spine of the mother. Okay, so think about it as being vertical or longitudinal or transverse. There can also be an oblique lie where the baby is kind of diagonal positioned in there. So this is a fetal scalp. Okay, it's just kind of showing you the bones in the fetal head, very similar to that of an adult, but you can see where there's openings. And these openings allow for molding of the head. And so these may overlap during the process of delivery, and you may note this on the newborn after delivery. But you can see the fontanelles, the anterior and posterior there as well. And this is just a view from the top of the head, pretty much showing you the same thing. These are different presentations, okay, that you might see. You don't have to memorize a slide, but just understand that we do refer to the baby as like ROP, LOP, so it depends on where the baby is facing in relationship to the maternal pelvis. And is the occiput presenting, and is it anterior, posterior, transverse? Okay, so position. So just kind of think about it that way. And you can see on the bottom there, the lie is longitudinal or vertical. The presentation is the vertex. Now, when we talk about the vertex, this refers to the top of the head with the baby's head flexed with his chin toward the chest. Okay, but also cephalic is head down. But you may hear those terms interchangeably. And then reference point is occiput. So it's going to be the head, okay, the back of the head. And you can see for attitude, and we'll talk about these briefly in a moment, it's general flexion. And so that's where the baby's head is flexed with its chin toward the chest. Okay, so the question in an LOA and ROA fetal position, so this is left occiput anterior and right occiput anterior. The presenting part is and you got that right, occiput, because it's the head. This is a frank breech, kind of explain that. And just for practice, it is a longitudinal or vertical lie. The breech is presenting, okay? Presenting part is the sacrum, and the attitude is flexion except for the legs at the knees. This is a footling breech. It happens to be a single footling breech. Sometimes I have both feet down there, okay? And so that's how we would describe it if we did have 2 feet. We'd refer to it as a double footling breech. If there's one, it's a single. But again, longitudinal lie or vertical breech, incomplete for presentation. The sacrum is a presenting part. The attitude is flexion except for one leg extended at the hip and knee. And this is a complete breech. They're pretty much Indian style in there, longitudinal lie, breech, and the feet are presenting because that's kind of what you're going to be feeling when you do a vaginal check. The sacrum with the feet, okay, presenting part, and then general flexion. And a shoulder presentation. You can see that baby is transverse. Okay, this carries a high risk of uterine rupture, this presentation. So if we discover this, the patient's in labor, we need to perform a C-section ASAP. Okay, which option isn't a primary factor in determining the presentation of the fetus during birth? And the answer to that is going to be fetal heart rate, B. And the reason why all the other ones have to do with the presentation. So let's talk about the passenger. So the fetus is a passenger. We talked a little bit about attitude. General flexion, the arms are crossed over the chest, thighs are flexed on the abdomen, and the legs are flexed at the knees. The biparietal diameter in a well-flexed head is the widest part entering the pelvic outlet. So this is why it's really important. The biparietal diameter is measured from side to side, okay, across, and it's the largest part. So we know if the baby has a really large biparietal diameter, we know maybe it's not going to fit, especially if we're talking a tiny, tiny woman. Okay, so sometimes we can predict, but a lot of these things really can't be predicted. The patient just kind of has to labor and kind of not progress for us to know that it's not going to happen. Okay, the suboccipitobregmatic diameter. So what that is, it's just more of a diagonal measurement diameter across the fetal head. So fetal position is position of the presenting part. Okay, and then we measure station. It's above or below the ischial spines. Engagement, the presenting part is passed through the maternal pelvic brim, and it's about a 0 station. Okay, so it lines right up at those ischial spines. And I have some pictures coming up of this. But you do need to know for testing purposes that engagement equates to a 0 station. And that's important because if a patient's laboring and the head is not engaged, okay, at a 0 station, the likelihood of them delivering vaginally is small, especially if the head is not descending to that station throughout the process of labor. Okay, so the patient may dilate and efface completely, but the head may not come down. So it's kind of floating up there in the false, what we call the false pelvis, before it reaches engagement. Okay, so just be aware of that. Okay, so we'll talk a little bit about attitude. So the top one there, the vertex, is ideal. And then the sinciput is more like they're kind of looking straight. And we also call this a military presentation. And then, of course, the brow, it's kind of when their head is hyperextended back. And that's the widest fit. And a lot of babies don't come out with a brow presentation. And when you do a vaginal exam on these patients, you're going to feel like an eye or a nose or the mouth or something. Okay, it's going to feel very strange when you go in and put your fingers in there to check them, and that's what you feel. Okay, so but look at the vertex presentation. You can see those orange circles. That's the smallest, and that's ideal. That's how we want the baby to be presenting. Okay, so fetal station. Okay, so the fetal station, again, this is a great diagram just showing you where the 0 station is, okay, at the level of the ischial spines, okay? As you go up, it's a minus number, okay? So when we do a vaginal exam and we report the exam to the provider, we're telling them about dilation. They're 4 centimeters. Effacement, which is thinning out. They're 50% effaced, and then we're telling about station, okay? They're a -2 station. And sometimes if they're -2 or higher, sometimes you may not even be able to feel the presenting part. Okay, and that's important for you to know if you have a patient in labor or you're doing an induction. Okay, we have to know that the head is presenting. And so oftentimes what we do if we can't tell with a vaginal check is we'll do an ultrasound to confirm head position. Okay, so that's what you need to do if you cannot feel a presenting part, or you just need to at least let the provider know that you're not sure what's down there. You think it might be head. And again, we talked about Leopold's maneuvers in the fetal monitoring lecture, so go back and review that because we look at fetal position with that. But again, that's not a guarantee either. So, and if you're ever in doubt about presenting part, get an ultrasound to confirm. Now, once they get below the 0, okay, this is where they become +1, +2, +3. So they're getting closer and closer to the vaginal opening. Okay, so usually by the time they're like a +2, you can see the baby's head. Okay, you can see it there. If you open the patient's labia and you look in there, you can see the head. And so you know they're getting close, okay, to delivery. Usually they are completely dilated and effaced by this point, by the time they're, in the coming down in the plus category. Okay, by the time they're +3, +4, they're pretty much crowning. Okay, so let's talk about the passageway. So this is a birth canal. The bony pelvis is a really important thing because they have to have the ideal pelvic type to be able to deliver vaginally, or it's not going to happen. And a lot of times what we do is we let the patient labor. They may have a very, very narrow pelvis, and you can kind of feel it when you check them. You're like, oh no, like there's no way a baby is going to come out of here, but I've been wrong before. So that's why we give women a trial of labor anyway. And usually what happens is they'll declare themselves. If their pelvis is not adequate or the head is too big for their pelvis, it's just not going to come out. Okay, so gynecoid is a classic female pelvis. This is really the ideal pelvic type. And then the android, this is a male pelvic type. And typically they cannot deliver vaginally with this pelvis. And the reason being it's a heart-shaped pelvis, okay? And so imagine something ahead, a round head trying to come through a heart-shaped opening. It's just not going to happen. And then you have an arthropoid pelvis, which is really more of an oblong-shaped pelvis. And women can deliver vaginally with these pelvic types, but a lot of times the baby ends up being occiput posterior. And so they're basically looking sunny side up because their occiput is against the sacrum. And it's just a tighter fit. The head is wider that way. And so it's a tighter fit through there. But some women are able to do it. So it just all depends on her and her body and the size of the baby, all those things. Now, there's a platypoloid pelvis type that is very flat. Okay, it's very, very flat. And there's no way a head is going to squeeze through there. So that's pelvic type is a vaginal birth is not possible. But I want you to make sure you understand at least these 2 pelvic types and which one is ideal for a vaginal delivery. Now, there's soft tissues. The vagina develops throughout pregnancy. It dilates to accommodate the fetus to permit passage of the fetus. Okay, the vagina, the tissue is very forgiving. It's very stretchy. It will accommodate in most cases. Okay, if we have women that are really morbidly obese and have a lot of tissue down there, it may be a little difficult, especially if you have a larger size fetus. Okay, so that may hold them up, and it may have labor progress slower due to that. So just kind of be aware of that. But typically soft tissue, it's pretty pliable. And so sometimes, we can even get in there and stretch it a little bit. So that gives a little bit more way. But, it can be a factor. Okay, which drug is a common ripening agent? Okay, so we'll talk about cervical ripening in a little bit, but your answer is going to be Cervidil or Cytotec. Okay, so we also use a balloon device. It's called a Cook balloon. It's got a double balloon. It's kind of like a Foley balloon that we do put inside the cervix to help with ripening. So we'll talk about that. Pitocin is more of an augmenting agent, but we do use it for induction, but that's only if they have a favorable cervix. And we'll talk a little bit about the Bishop score, but the Bishop score is really what we go by. And there is a Bishop score chart in your required reading. I want you to take a look at that because you're going to have to know which number or which score they have to be to qualify for Pitocin and what kind of score they're going to need to qualify for cervical ripening. And typically a Bishop score over 6, 5 or 6, depending on the patient, they're favorable for Pitocin, which means they don't really require any ripening. Women under that typically do. Okay, so we kind of go by that to determine how we're going to induce the patient. Okay, so this is just a diagram showing you a little bit about how the uterus stretches. The walls of the uterus get thinner as labor progresses, and the cervix will thin out, it will open. And remember, it's a muscle, so it's going to stretch. Okay, this one is showing you, even more effacement and dilation. The one on the right there, now pay attention to that. There's a pathologic retraction called a Bandel's ring. Now, this occurs when the patient has been laboring a long time, and they ultimately usually end up a C-section, but they labor a really long time. And what happens is the uterus is adequately contracting, but she's not making change, or the baby's not descending into the pelvis. So the uterus will do this. It will create this ring. So when you go in and do a C-section on these ladies, you can actually see this band on the uterus, and it's like crazy because they can rupture their uterus from this. So this is why we don't want to just let people labor forever and ever and ever. We have to have a cutoff at some point. And that's why we usually go by the 4 hours, give or take an hour, if the patient wants a little bit longer, but generally speaking, if the contractions are adequate, she's ruptured, she's on Pitocin, her Montevideo units, which where we measure the contractions to see if labor is adequate. If those are above 200, we take the peak of the contraction for 5 contractions, subtract the resting tone, and then we add those numbers up. And generally, if they're over 200 on those units, that's adequate labor. So if she's had adequate labor for at least 4 hours and she's at least 6 centimeters dilated, then we can safely call her failure to progress. So otherwise, we give them more time. But this is the problem that happens if we kind of go past that and we go a little too long, as they can develop this Bandel's ring. Okay, so this is just showing you cervical dilation. So generally speaking, when we do a vaginal exam on a patient, we're pretty much putting 2 fingers inside the vagina. We're putting on a single sterile glove. Even though it's really not a sterile procedure, we do use sterile gloves. We put it on, we can get 1 finger through the cervix, we call that 1. Okay, if we can wiggle it around a little bit, it's 2. Tight 2 fingers in is 3. And then you have your Oreo there, that's 4. About 5 to 6 centimeters is a soda can top, 8 centimeters around the width of a donut. And then once they reach complete dilation and effacement, you won't feel anything except the presenting part. Okay, that's all you're going to feel. All the cervix is gone, out of the way. Okay, so you shouldn't feel anything. So that's why you have to be really careful when you're checking them at the end to make sure you don't feel any cervix. Because sometimes there's a little bit of a rim around there, and we don't really want them pushing against that because they could tear their cervix. Okay, and so which can cause damage down the road. So we want to make sure that they're complete. When we say they're complete, that means no cervix, no no cervix at all. Okay, so let's talk about the powers. These are going to be your contractions, okay, the primary powers. And we measure this, remember, frequency, duration, intensity, and also resting tone. These are the things that we document. Now, I want you to go back and make sure you understand that fetal monitoring PowerPoint and lecture, because that's where we talk about those in more detail. Okay, and you will be quizzed on this terminology, so make sure that you go back and review that. And again, we're looking at effacement, dilation. Now, the Ferguson reflex is a maternal urge to bear down. This is a natural reflex. She can't really control it. It's involuntary, and it's caused by pressure from the fetal head coming down. Okay, so that's kind of how we know the patient's close to having a baby, because usually their demeanor will change. And I can tell you, I know a patient is usually 8+ centimeters just by the way she sounds when she's contracting. If she's having that groaning sound, like she's gonna has to bear down, I know she's close to having a baby. Okay, because it changes from when they progress from active labor to transitional stage. Okay, and so that's how we really know. Um, and most women without an epidural don't have any problem pushing, okay? They don't really need coaching. If you have a patient that has an epidural, it's a little bit more difficult because it wipes out a lot of this Ferguson reflex. Some of the patients still feel pressure, which is good. It's always a perfect epidural if they can feel pressure. But sometimes they get completely wiped out and we have to turn the epidural in half or turn it off just so the patient can feel enough to push. So that's kind of what we have to do sometimes. And they may need a little bit of coaching. But the best thing to do is have that patient take a deep breath. When the contraction is starting to climb, we tell them to wait until it builds up and it reaches that peak of the contraction. Then we have them go ahead and push. And usually have them push as long as they can that first time. And then just go right back into it, take another breath and go back into it and get what they can out of it. Okay, we do want them to use the most of that contraction, but we don't want them holding their breath for three times for 10 seconds, because that's also known as closed glottis pushing, and it's not recommended in the literature. Babies actually lose oxygen over time when we're having them do that. So we really want to encourage open glottis pushing, which is kind of them pushing when they feel the urge, or pushing but not for such long periods of time of holding their breath. Okay, and this is just kind of showing you how the cervix dilates, effaces, and as the head's coming down. And so you can see how it's evolving over these 4 pictures. And then by the time you get to that last one there's maybe a little bit of cervix around the head, but pretty much you just can feel a head. And the baby is pretty low in the vaginal canal. So that's good. Okay, so positioning of the laboring woman. So positioning is really important, and sometimes this can make or break whether she delivers vaginally, believe it or not. And so as nurses, it's really a lot of our responsibility to make sure these patients are getting moved, especially with epidural. You don't want to just let them lay there. Okay, you want to move them from side to side at least every 30 minutes. Okay, and a lot of times with women with epidurals, we use what's called a peanut ball. And the peanut ball is like a yoga ball, except it's peanut shaped. And so we put it between their knees, and it keeps their hips open and allows for descent. So that's a great thing about the peanut ball. Okay, so upright position is good, walking, sitting, kneeling, or squatting. So all 4s, especially if the baby's in an occiput posterior position. This will often help the baby rotate around to an occiput anterior. And a lot of babies will rotate around in the process of labor. Okay, lithotomy, you're going to see most women in this position, especially when they deliver. And it's really not the ideal position, okay, because they're on their back, flat on their back. Okay, we need to be allowing women to labor and deliver in the position they're most comfortable with. It's really not that big of a deal. Okay, I did this for 8 years as a midwife, and I had patients deliver in a squatting position. I had them delivering on hands and knees, side lying, whatever. Okay, so we have to kind of help accommodate the patient as well, whatever she's most comfortable. And not all women want to be flat on their back. Okay, so we just have to keep that in mind. Okay, so lateral again helps the baby rotate again. And sometimes I move that patient all the way over, like their belly's almost touching the bed, because that's going to help baby rotate um, the other way. And so always keep in mind positioning as a part of the labor process. Okay, and here's just some positions that are good for them to try. And then on the next slide, um, there's more. Okay, so you can see that a lot of the labor rooms, the beds have squat bars. There's different things that you can do, different things they can try, and they're going to be more comfortable this way if they're able to have mobility and move and be in positions that they're comfortable. Okay, psychological response. And I want to say too that positioning can also affect the psychological response, because if they're just laying in a bed and not moving around, they have more time to think about how much pain they're in. Okay, so they kind of feed off each other, these P's of labor. Okay, so the psych is unique to each woman. Sometimes there's cultural beliefs. They may not believe in epidurals. They may not believe in pain meds. They may believe that going natural is what they do, okay? And then previous experience. Do they have a horrible birth experience? They may have fear or more anxiety due to that. So sometimes it's good to kind of figure out where people are when they come in. Like, what do they want for pain management? What are their expectations? So kind of get a feel for the patient and what's going to make them more comfortable. Because the more comfortable you make them, the more relaxed they're going to be. And sometimes that's just even showing them the kitchen, showing them where to get food, showing the partner where to get food or water, whatever they might need, extra blankets. So all these things will decrease anxiety level, and just the nurse's presence at the bedside. I mean, I can't tell you how much nurses hang out at the nurse's station and talk, and their patients in their room, and they're miserable. Go in there, provide support, if you can. Sometimes it does get busy, but providing support is really important, and just nurse presence at the bedside. Okay, so some women will want their environment set up that way, where they have maybe aromatherapy, they have light music, they have lights, it's quiet. So if they're setting their room up and their environment for a soothing environment, sometimes this helps a lot with the psych. Okay, so the labor process really involves the process of moving the fetus, placenta, and membranes out of the uterus and through the birth canal. So pretty much expelling all the contents of the uterus. So signs preceding labor include lightening. Lightening means the baby's descending in the pelvis. Sometimes it's the same thing as us saying the baby dropped, okay? Bloody show is a really great indicator that labor is starting. It's like a mucus plug, but usually bloody shows a little bit more. They can lose their mucus plug a couple weeks before they deliver, so it doesn't really mean it's going to happen. Some patients will come in and say, oh, I lost my mucus plug. But it doesn't mean they're really in labor. Okay, maybe soon they're probably effacing a little bit or dilating to dislodge that mucus plug. But usually bloody shows kind of more, okay, the cervical fibers are breaking down. Okay, there's little blood vessels, and those little blood vessels break. And so that's what causes this bloody show. It's like a cervical mucus um, discharge that occurs. It should not be bright red bleeding like a period. Okay, there's always something else going on. So bloody show is usually very little blood, usually pink tinged. As they get a little bit more dilated and closer to delivery, it's going to become probably a little bit more, but that's what you would expect to see. And then the onset of labor, we know, isn't ascribed to one single cause, but there are fetal and maternal factors that involve hormones. So you do have an increase in estrogen and prostaglandins and a decrease in progesterone level. So if you remember, estrogen kind of causes havoc. It kind of makes things swell and, ooze and all of that. So it is responsible for initiating contractions, along with the release of her own endogenous oxytocin. Okay, and then prostaglandins, again, they're going to break down those fibers of the cervix, and the patient makes their own prostaglandin. Okay, and then that's usually pretty much what it is when we give them ripening agents. They're prostaglandin medications. So your Cytotec or misoprostol and your Cervidil, those all have prostaglandins in them. And decrease in progesterone, as we said, because that's what keeps the uterus quiet during pregnancy. Okay, so the first stage of labor is the longest, okay, at the latent phase. Okay, so you have some effacement of the cervix. Usually the woman is completely unaware of it, and she may dilate, especially if she's a multiparous patient, she's had a baby before. Okay, so it's not unusual for a patient to come in, for a visit, and they're like 37 weeks and they're 3 centimeters dilated, okay, and they're not in labor, okay, so it's not active labor, okay, it's kind of happening latent. Active is rapid dilation of the cervix and increase in descent in the presenting part, and this is how we know. And we talked about 6 being the cutoff for labor. They used to say, oh, everyone that's 4, they're in labor. We don't treat all people the same. We know women don't labor at the same rate. Okay, so, but we're calling it too early too. Women are older, having babies, or do we have higher BMIs? So that's why some women may not be in active labor till they're 6 centimeters. So that's why we want to use that as a cutoff to say, okay, they haven't progressed. But a woman's in active labor versus false labor if she's making appreciable cervical change. Okay, if that cervix is dilating, it's effacing, she's usually having regular contractions that are increasing in intensity, okay, over time. That's really how we know the difference. Otherwise, they're kind of just contracting and not really much is happening. And a lot of times if they present to labor triage and they think they're in labor, usually what we'll do is we'll check them and then maybe send them for a walk, have them come back an hour later and we'll recheck them. If they're changed, they're in labor. Sometimes some women come in, it's very obvious they're in labor. I mean, they're breathing heavy through contractions and we check them and we can immediately admit them, so we know. But some women, it's not always clear. So sometimes we have to send them for that walk and see if they are. Because we really try to avoid admitting patients that aren't in active labor, because that means more interventions. And the more interventions we do, the more we're setting them up for complications. So that's why we really try to wait till they're in active labor to admit them. Now, transition is kind of that area where I was talking about the Ferguson reflex. They're kind of 7 to 10, they're kind of getting toward the end there. And so transition, the woman has a very different demeanor. Okay, again, she's having kind of that bearing down feeling, but women also get very kind of irritable during transition. They don't really want to be touched. They don't want to be talked to. A lot of times they swear. I mean, that's not uncommon for that to happen. But they are getting closer. And so we even see a change in the demeanor. And I've always told students, I could tell what phase of labor somebody was in just by their demeanor. Okay? And it's like, they're getting close if they're in transition. And they also get very, very shaky. They get kind of involuntary shaking. Their body is going through, a vigorous process to get this baby out. And so, especially epidural, you'll see them get really shaky, but they'll even do it without an epidural. So that's your clue. That tells you, like, okay, this patient's getting ready. And then the second stage, there's 2 phases. Again, they're fully dilated and fully effaced. All you feel is the baby's head. That's all you can feel once they reach the second stage. And sometimes they may have some contractions and they kind of peter out a little. They kind of slow down. And so that's what we call the latent phase of the second stage. But once they get active, this is kind of like the grand finale. Okay, they're contracting every 2 to 3 minutes. They're pushing, they're feeling a lot of pressure, and this is where she pushes until she delivers, okay? And the third stage is birth until the placenta delivers. And then fourth stage is 1 to 2 hours after delivery of the placenta. Okay, you need to know this slide. You need to know the stages of labor because you will be asked questions about it. Okay, and this is just kind of showing you. And you don't need to know those numbers on the left, okay, because again, all women are different. They may not be in active labor at the same dilation, okay? So, but just have a general idea of what's in each phase. Okay, so the mechanisms of labor, and this is really, I kind of think of the cardinal movements as like Tetris, okay? So this is like maneuvering through the pelvis. So in order for the baby to deliver, they kind of have to go through the 7 cardinal movements of labor. Okay, so this is going to be engagement. That's the first thing that happens. Okay, if they don't even reach that, they're not going to go through the cardinal movements. Okay, so again, this is a 0 station. They have descent, latent to active, okay? Flexion, chin closer to the chest, smaller diameter. Internal rotation, fetal head is guided into the correct position. Extension, fetal head under the symphysis pubis. External rotation, so delivery of the anterior shoulder. Expulsion is delivery of the body of the baby. Okay, so this is basically what they do once they come out. Now, if you watch the shoulder dystocia, lecture, you'll know that once they get to external rotation, that doesn't occur because the shoulder is stuck. Okay, so make sure that you understand that and you're reviewing that video as well, because you may be asked questions about that. Okay, so this is just showing you again engagement and descent, flexion, baby's chin to chest, internal rotation to occiput anterior, extension, external rotation beginning, and then external rotation is complete. So that shoulder is emerging and it's delivering. Okay, and then what's the longest stage of labor? And the answer is the first stage. Okay, which occurrence is associated with cervical dilation and effacement? And the answer is bloody show. Okay. Transition is transition is part of which stage of labor? And your answer should be the first stage. Remember, it's the last part of the first stage. Okay, so physiologic adaptation to labor, so the fetus is very, very resilient, okay? They handle a lot during labor, a lot of oxygen deprivation, but usually healthy fetuses can overcome that. So we do periodic fetal heart rate accelerations and slight decelerations, and not all babies will have accelerations. If they have moderate variability, that's really good. Decelerations may include things like early decelerations, which are benign. Okay, so that's kind of what we mean by slight decelerations. It probably should be worded a little bit different, but they may have variables with pushing, which is common as well. Decrease in circulation and perfusion, but again, usually they can handle that. Increase in arterial carbon dioxide pressure, decrease in fetal breathing movement because they're getting squeezed. Decrease in oxygen pressure, decrease in partial pressure of oxygen, fetal respiration, so fetal lung fluid is clearing during labor and vaginal birth because they're getting that thoracic squeeze, okay, in the vaginal cavity. So that helps clear the lungs out in preparation for baby to take that first breath of air. So women exhibit both objective and subjective symptoms. So cardiovascular changes, increase in cardiac output is going to be 12 to 31% in the first stage of labor and 50% in the second stage while they're pushing. Increased heart rate, cardiac output, blood pressure during contractions. But again, these just should be slight elevations. These should not be like in preeclampsia range blood pressures. Okay, if you're getting blood pressures and that reading, you need to get labs. Okay, especially if they're kind of just doing it, or they're a little bit high when they come in. We've had that happen. Increased white blood cell count. So we talked about labor at the level of the cervix, the prostaglandins, it's an inflammatory process. So that's why women have high white counts in labor and immediate postpartum. So that's expected, and it's normal as long as a patient is afebrile and not showing other signs of infection. Increased respiratory rate and oxygen consumption. So maternal physiologic response to labors, they do have decreased gastric motility and food absorption, decreased gastric emptying and gastric pH, which sets a lot of women up to vomit in labor. It's not uncommon for women to vomit, okay? That's really normal, especially transition. That's another sign your patient's getting ready to deliver, is she's throwing up, okay? So you're kind of thinking, oh, good, she's going to have a baby soon, even though it's not a pleasant thing. And we tell patients it's a good sign, even though it's not a pleasant way to get there. Slight temperature elevation, again, this should not be high. It should not be like fever range. It shouldn't be 100.4. It should be lower than that. Muscle aches and cramps, increased BNR, and decreased blood glucose levels. She's working really hard. Labor is a workout. Labor and birth are affected by the 5 Ps, okay? Passenger, passageway, powers, position of the woman, and psychological response. And just remember, these all have to interplay and coincide with each other for her to have a vaginal delivery. Because of its size and relative rigidity, the fetal head is a major factor in determining the course of birth. Again, remember the molding I talked about. Diameters at the plane of the pelvic inlet, mid-pelvis and outlet, plus axis of birth canal determine possibility of vaginal birth, and manner in which the fetus passes down the birth canal. Okay, so this influences those different positions, whether it's occiput anterior, occiput posterior. Ideally, remember, it's an occiput anterior position because that's the smallest fit through there. Okay, it's going to be the smallest, the head's going to be the smallest through there. Involuntary uterine contractions act to expel the fetus and placenta during the first stage of labor, and augmented by voluntary bearing down efforts during the second stage. The first stage of labor lasts from the time dilation begins to the time when the cervix is fully dilated. Second stage of labor lasts from time of full dilation to birth of the infant. Third stage of labor lasts from infant's birth to expulsion of the placenta. And then the fourth stage is going to be the first 2 hours after birth. And then remember your 7 cardinal movements. You're not going to be quizzed on the 7 cardinal movements, but just be aware that this mechanism, they have to at least reach a 0 station in order for all of this other stuff to happen. Okay, so again, engagement, descent, flexion, internal rotation, extension, restitution, and this is kind of where the baby's head goes to the left or the right, so you kind of know if it's LOA or ROA, and external rotation and expulsion of the infant. Although the events precipitating onset of labor are unknown, many factors are involved. So changes in uterus, cervix, and pituitary gland, which releases hormones. And that is it.